Next, I'd like to introduce Dr Sherman Picardo, who is one of our new gastroenterologists that's joined us both at Royal Perth Hospital as well as Perth Gastro and Liver Care. Sherman trained here at UWA and then did gastroenterology training in our program. He then specialised in inflammatory bowel disease and went off to Calgary in Canada, where he was there for over a year doing his fellowship in inflammatory bowel disease. But tonight he's going to talk about irritable bowel syndrome. We know that the majority of these presentations are all managed in primary care, so hopefully he can deliver some tips and some ideas on how to improve management of these patients. So thanks, Sherman.
Thanks, Nick. Hi everyone. It's good to see so many people come out tonight. I'm going to be talking on managing the patient with irritable bowel syndrome, IBS. And IBS is probably the most common GI condition affecting our patients, so it's often something that we see in practice. And it's good to have a good approach to managing these patients, and I'll try and outline some tips today. So the aims of my talk, I'll outline our current understanding of IBS. IBS is sort of a diagnosis of exclusion, but not everyone needs to be investigated with all the tests we do. So we'll look at when and how to investigate further, and then some practical management tips looking at lifestyle, diet modification, and some of the medical therapies that we use. So what is irritable bowel syndrome? So we break down each of the terms and look at the definitions. Irritable, the definition is excessively excitable or sensitive. Bowel refers to the intestines, both the small and the large intestine. And a syndrome, it's a group of symptoms that collectively indicate or characterize an abnormal condition. And this appropriately reflects IBS. So it is a group of GI symptoms that come together in a characteristic way. And these symptoms may be different in different patients. They may have different mechanisms or triggers, and that's what makes it challenging to manage. So what are some of the symptoms? So I've listed some up on the slide there. So you can get increased mucus production with your stool. Tiredness and fatigue are often related with IBS. There is an overlap with a number of other chronic conditions, so chronic pain syndromes, fibromyalgia, as well as anxiety and depression. So we often see our patients have tiredness and fatigue as part of the syndrome. Patients often can complain of this sensation of incomplete emptying. So you've gone to the toilet, but you still feel something's there. You still need to empty your bowels. Flatulence and bloating are also very common symptoms of IBS. But the main symptoms, and these are the symptoms that sort of characterize the diagnostic criteria for IBS, is abdominal pain, altered bowel function, and the altered bowel function can be change in consistency or frequency, and a temporal relationship between the two, so pain on passing a bowel action. Now, IBS is a chronic problem, so some of those symptoms I've mentioned, I'm sure everyone has experienced some of them at some point in their lives. If you have something like a spicy curry or something like that, you often do get discomfort or need to run to the toilet. Have alcohol, have a beer, you often get bloated. But IBS, it's characterized as a chronic problem. So as part of the diagnostic criteria, you usually need to have symptoms for at least 6 months. And also, usually symptoms on average at least 1 day a week over the last 3 months. And that differentiates IBS from the occasional symptoms or symptomatic episodes. Now, IBS is a serious issue. It's very common, so 10 to 20% of the population has IBS. And IBS doesn't discriminate, so it's a problem worldwide. All socioeconomic groups, people of all different cultural backgrounds, they all have IBS. It also has a significant economic and social cost. So this is based on some of the studies out of the US. So absenteeism from work or from school, it's the second most common cause, the first being colds and upper respiratory tract infections. It also has presentism. So this refers to, even though you're able to attend work or school, your performance is suboptimal. So they've compared patients with a diagnosis of IBS and those without, and those with an IBS, even though they're able to attend work, their performance is suboptimal. And it can be extremely debilitating and diminish a patient's quality of life. So we'll just move on to a clinical case. So this is one I saw a couple of years ago. EW, 26-year-old female. She's got a medical history of polycystic ovarian syndrome, but it's controlled on an oral contraceptive pill. Psoriasis. She does also have a history of anxiety, not on any medications, but does engage with a clinical psychologist. In terms of work, she works in HR in a busy office. No significant family history, and she's living with a partner and no children at present, but thinking about that in the future. She's a non-smoker. And so she presents central abdominal pain, sort of varying severity for several years, bloating, intermittent bloating, and she does describe hard stools. She's had to use laxatives intermittently to help with the bowel actions, and she describes relief on passing stools. But more recently, she's noticed a change in her stool pattern, so she's now gets semi-formed stools 2 to 3 times a day, and she's waking up at night to go to the toilet. No bleeding or mucus and no weight loss. This is just some general blood work, pretty unremarkable, normal inflammatory markers, full blood count, electrolytes. So at this point, the question is, she's a young female, does she meet the criteria for IBS? And should she have any further investigation? What investigations should we do? Does anyone want to comment, or is anyone happy with the diagnosis of IBS, or do you think it needs further investigation? Yep.
I think should consider ruling out experimental bowel disease.
Yep.
So at least this could test MCS and parasite removal and also cut protected.
Yep. Was there anything you were worried about in the history that, or just her age, or was there the history that points to that, or? The night symptoms are important because that's something unusual, and as I think Cannon mentioned, that it usually indicates some sort of pathology. But you're right. I think there are some further investigations that we need to do. And further investigations, we mainly need to exclude some of the other causes of either diarrhea or pain. Cannon's went through a lot of them, so I've just summarized them there, but mainly the malabsorption conditions, infectious conditions. So this is many chronic infections, so we're looking more at bacterial overgrowth and parasitic infections, the inflammatory bowel diseases. The other thing is psychological conditions. I mentioned there is that overlap, so anxiety and depression. Often patients with these, with anxiety or depression do have these somatic GI symptoms, so it's important to exclude those. Dietary conditions, and the other thing is more serious conditions, but these are more rare. So the GI cancers, neuroendocrine tumors, endometriosis, and thyroid dysfunction. So in general, there is no definitive diagnostic test for IBS, but there are some recommended sort of baseline tests that should be performed, and this is from the American College of Gastroenterology. So full blood picture, CRP, that can help with inflammatory or infectious conditions. Everyone should have a celiac serology, a simple blood test to exclude that. Stool MCNS plus parasites, because it is a chronic condition. Cannon's already gone through fecal calprotectin, so there may be a role for that, but it is not reimbursed at the moment. So has anyone sent patients off for a fecal calprotectin? Yeah. So hopefully it should be coming. I think it's going through Medicare at the moment, but it costs about $70 to $80 at the moment for patients in most of the labs to offer it. And the other thing is colorectal cancer screening. So if you meet the criteria for colorectal cancer screening, either the FOBT based on age, or maybe more frequently if you have family history or a cancer syndrome, they should have that appropriate colorectal cancer screening. But there are alarm symptoms, and these alarm symptoms do suggest that something else may be going on. And when you pick up these alarm symptoms, they often should have further testing, either imaging, endoscopy, or colonoscopy, or referral to a gastroenterologist. So age over 50, that's when we get worried. We're more worried about the development of cancers, a short symptom history or new symptoms over the last 6 months, rectal bleeding, unintentional weight loss or unexplained fever that can indicate both infection or malignancy, nocturnal diarrhea, which you've mentioned, that indicates secretory diarrhea and is generally associated with some sort of pathological condition. If there is a family history of inflammatory bowel disease, celiac or GI malignancy, palpable abdominal mass, or any extraintestinal symptoms, particularly inflammatory conditions. So if they've had arthritis, rash, ocular symptoms that may indicate inflammatory bowel disease. And even today, I had a patient for a colonoscopy, a recent diagnosis of ankylosing spondylitis, HLA-B27 positive, and only very minor GI symptoms, cramping and about 2 to 3 stools a day, but a scope showed some early changes of ileocolonic Crohn's disease. I'll skip through fecal calprotectin because we've already covered that in the last talk, but just getting back to the case, so there was those alarm symptoms. She ended up having a stool culture which was negative, a moderately elevated fecal calprotectin at 370, and went on to have a colonoscopy which demonstrated some changes consistent with Crohn's, so the ileal ulceration and inflammation, and biopsies confirmed that. And she's been managed very well on medication, but she still has this ongoing sort of symptoms, gone back to the constipation and bloating. And I just brought this up. Often with the GI conditions, you do have this overlap with IBS. So you're managing the condition, but you also may have this overlap. And so it's important to deal with those symptoms as well. I'll come to treatment a bit later. We'll just move on to a second clinical case. So this is one I saw last year. This is NM, a 16-year-old female. She was in year 11 at the time. No past medical history or significant family history, but originally from Sri Lanka and moved to Perth at the age of 5 and currently living at home with her parents and younger sister. So she actually was referred as a direct access endoscopy and colonoscopy because she'd presented to the emergency department on 2 occasions with right-sided abdominal pain. During her admissions, she had surgical review. It was unremarkable, normal blood tests. Her initial ultrasound, there was a comment of query appendiceal tip thickening, but they didn't clinically think there was appendicitis, and a repeat ultrasound was normal. But she'd also had issues, long-standing abdominal pain, loose semiform stools 3 to 4 times a day, and no nocturnal symptoms, bleeding or mucus or weight loss, and clinical examination was normal. Her blood work, pretty normal. The calprotectin, there is that concern about what the cutoff is, but as was the lab that we use, the cutoff was 100, so this was just above 101. But she was coming for the gastroscopy and colonoscopy, so that was completely normal macroscopically. Duodenal biopsies were normal, colonoscopy was normal, biopsies in the colon did not show any inflammatory changes. By the time I reviewed her in the clinic after the endoscopy and colonoscopy, she reported that actually she was going through the exams when she presented to the emergency department. It was year 11 exams, and that was a big trigger for her symptoms. And now that I'd seen her in clinic, her symptoms had actually improved. And we made the diagnosis of IBS-D. So I'll just briefly go through the subtypes. I'm sure you're all aware of some of the subtypes. It's characterized as 3 main groups, so IBS with constipation, IBS mixed, or IBS with diarrhea, and it just depends on the proportion of hard and loose stools. And that's important in terms of our approach to treatment. And again, Cannon mentioned the Bristol stool chart, so usually type 1 or 2 is hard, type 6 or 7 is considered loose. So I've just listed some of the proposed mechanisms in terms of IBS, and this is a complex field. There's a number of different proposed mechanisms and theories. And we still don't know the exact cause in different people, but there's a number of different proposed causes. So one is this altered gut flora. There's a lot of research into the microbiome in a number of GI conditions, and IBS, that change in the flora may contribute. So often after a course of antibiotics, patients may get these grumbling bowel symptoms, or even after an infection, you can get post-infectious IBS. So that alteration may play a role. A lot of the patients, particularly with pain, may have visceral hypersensitivity. So sort of the response to normal stimuli, that some people might not have that sensation. Other people have a heightened sensation. So to bloating or constipation, they sense that, they have that heightened sense, and that causes the discomfort. There may be an alteration with the brain-gut interaction, as well as psychological stress. I've mentioned that overlap already. There's a lot of neurotransmitters involved in gut regulatory function, so dysfunction of that may contribute. And dysmotility is a big contributor in IBD with constipation. IBS with constipation. All right, so we'll look at some of the therapeutic options. So whenever there's two sort of factors that we think about when we make treatment decisions with IBS. One of them is the type, so you sort of treat the type of symptom. And the second the factor is the severity. So most patients with just mild symptoms often respond to simple measures, so change in the diet or lifestyle changes. And we'll go through some of those specific ones in the next few slides. But as you have more severe IBS, there are more factors involved, and that's when you've got to think about medications, behavioral therapies, and antidepressants or neuromodulatory medications. So just a brief summary of lifestyle modifications. I think everyone should bring this up with patients and approach these. The two big lifestyle modifications that should be recommended are exercise and sleep. So I'm sure everyone that does exercise, it's useful for a number of conditions, but when you exercise, you do feel better, and your gut tends to feel better. And there have been some meta-analysis that have shown improvement in GI symptoms, quality of life, and anxiety in patients with IBS. The efficacy compared with the other therapies, the medications and diet, there's not much evidence for that, but it does seem to improve a number of symptoms in IBS. The other main factor is sleep. So there has been association with poor sleep quality in patients with IBS. And that sleep can be either disturbed or interrupted sleep, or not enough sleep. And that correlates with IBS-related pain and discomfort and poorer IBS quality of life. So it's important to ensure that all our patients are not having disturbed sleep, getting adequate sleep, and now I'm sure all of you have, with the modern phones, they've got all the sleep apps and things to help stop disruptions with the lights and the noises overnight. So moving on to targeted therapies. So it's the therapies are targeted at mainly at the symptoms, and there's different therapies that we use for different symptoms. So in terms of bloating, if there's bloating predominance, low FODMAP diet can be useful, and I'll go through the low FODMAP diet because that's useful for a number of the different symptoms. But other dietary modifications, there are a lot of diets that can increase bloating. So caffeinated drinks or carbonated drinks, alcohol, avoiding these sort of foods can reduce bloating. There are some over-the-counter medications. So the evidence for these medications, some people do find benefit, but it's sort of a trial and error. They tend not to have significant side effects, so it's appropriate to try and see if they are effective. So the ones you can get over the counter: peppermint oil, iberogast. That's a herbal preparation. I think 8 or 9 herbs that can help with a number of GI symptoms, including bloating, and simethicone. So that's in Infocol. They often use it for babies. I've mentioned rifaximin here. So rifaximin is an antibiotic. It's used for a number of conditions. But there was a big trial published in America in the New England Journal of Medicine that did demonstrate benefit for a short course of rifaximin for IBS, including bloating and diarrhea. The only issue is it's not approved on the PBS for this indication in Australia. So moving on to pain, again, low FODMAP's effective. There are antispasmodics that we can use, so hyoscine or mebeverine. If it's not working with the simple measures, then we can progress to more potent medications. And the common ones that we use are low-dose tricyclic antidepressants, and they have neuromodulatory effects as well as the effects on depression and anxiety. Further down the track, sometimes we consider things like pregabalin and gabapentin. If constipation is the main contribution to pain, fiber may be helpful as well. In terms of constipation, again, dietary modification and supplemental fiber. I've mentioned the footstool. Has anyone used the footstool in the toilet? So the best mechanism, the best way to defecate is is having the legs elevated by squatting, essentially, and that's the best sort of anatomical design to pass a stool. So having a footstool just in front of the toilet, you're lifting your legs and promoting a relaxation of the pelvic muscles, and that helps patients pass stool easily without the need of medication. So always, if constipation is a big problem, that's a good technique to use. Laxatives, of course. So we prefer osmotic laxatives. Stimulant laxatives are the ones that you can develop resistance to, so we tend to use them for short periods of time. And I've mentioned prucalopride. This is a serotonin 5-HT4 antagonist that helps with colonic motility. It is approved by the TGA in Australia, but not on the PBS, so a patient has to pay out of pocket for that. But we have used it for resistant constipation cases. And diarrhea, again, low FODMAP, antidiarrheals, loperamide, cholestyramine, and again, tricyclic antidepressants. So I'll just go a bit more in detail with the low FODMAP diet. And yeah, the image, I'm not sure if you can see it that well, but FODMAPs stand for fermentable oligosaccharides, disaccharides, monounsaccharides, and polyols. And these are short chain carbohydrates that the body poorly absorbs. And so they have a number of effects. So these carbohydrates in the small intestine, they act on a number of receptors, and they draw water into the small bowel lumen. So with that, you get small bowel distension, but you also have increased fluid in the stool, so that promotes diarrhea. But when they reach the large bowel, that's where they are fermented. They're not digested, they're fermented in the large bowel, and then that's where you get gas production. You get luminal distension with the gas, and that's the symptoms of bloating, as well as pain from stretch, as well as increased flatulence. So minimizing these FODMAPs is an important component of managing a lot of the symptoms of IBS. And it's effective for about 50 to 75% of patients. So on the right, it doesn't project that well, but that's some of the foods, the different subtypes of the FODMAPs. And I'd recommend definitely engaging a dietitian to go through this. They're the best. They can talk the patient through the different the subtypes and how to go about the diet, but typically they exclude everything at the start, and they slowly introduce different groups of FODMAPs, and then try and identify the trigger foods, and they're the ones to be avoided. So going back to our patient, we engaged with a dietitian, commenced on the low FODMAP diet, and found to have issues with lactose and the galactans, and had significant improvement in her symptoms. The other thing is psychologist. Our patient declined a psychology input. She had that sort of stress relationship with her symptoms. Now, there is an online module. Our patient was not appropriate, but there is an online module. Has anyone come across this or used this before? The IBS mindovergut.com. So this is an excellent resource in terms of psychology input specifically designed for IBS. It was created by a clinical psychologist in Melbourne. It's free to use, and it has a number of online modules that gets patients to go through sort of some basic CBD training, as well as resilience training, and specifically for IBS. They're about 40 to 50 minutes each module, 4 or 5 modules, and it's available to everyone in Australia over the age of 18. But definitely worthwhile. Have a look at that site, especially in the patients that don't really want to engage with a psychologist. This is a very useful website.
How long it can take to identify the food group which the patient is sensitive to when we refer patient to dietitian?
Yeah.
It's like many weeks or?
Yeah, so the question was how long to identify the sort of food group that triggers the patient's symptoms. So different dietitians work differently, but generally there's a period of exclusion initially to see if it works. So you exclude everything, and that's usually for about 4 weeks. And then over a period, and it can be up to 6 months, you're slowly introducing different food groups and trialing different food groups, and then identifying the trigger causes. And if something's working, you continue with that food group. You don't want to keep on the FODMAPs continuously. You do want to try and reintroduce the food groups. But yeah, it can be up to 6 months. All right. So just a bit more about psychological therapies. There are a number of different more specific psychotherapies that are effective for IBS. But I think it's mainly identifying the patients that are going to respond to these therapies. So you want to pick your patients that sort of have that stress anxiety component as part of the IBS, and those that are willing to engage with a therapist to see if they can work through these to improve their symptoms. Just some more resources. So the GISA website, so that's the Gastroenterological Society of Australia. They've got an information sheet for patients, which is very useful. If you want more information about the low FODMAP diet, it was developed at Monash University in Melbourne. They've got a large amount of resources on their website, and they've also got the phone app. So the phone app is something that patients can download. It does cost a little bit. I think it's $11 or $12. But it has information. But even in the shops, you can identify foods which the different FODMAPs in certain foods. So that's very useful. I've mentioned the IBS Mind Over Gut site. And for doctors, so the GISA has a website, ibsforgps.com. Has anyone seen that one? So yeah, this was developed a couple of years ago by GISA, and it has a lot of resources for GPs, what investigations to do, further information about the different therapies, ways to approach dosing. So it's really useful. Just log in and go through the choose the section that you want. So yeah, if you want that one, great. So yeah, this is just an example. This is the summary slide from that website, and it just covers the diagnostic treatment algorithm. And I've gone through most of it, but it may need to exclude the alarm symptoms. If there are alarm symptoms, further investigation. It goes through the regular investigations to use and then approach to management. So I'll finish there, but thank you, and I'll take any questions that anyone has.
No questions?
Yeah.
With the increasing prevalence of bowel cancer in the young, how long do you wait before you scope in a 25-year-old?
So yeah, we are seeing more younger people with, the question was with the increasing bowel cancer in the young, how long do you wait before you scope? So I think we are seeing a lot more young people with bowel cancer. I think if there is particular risks, family history, or any of the red flag symptoms, then definitely go ahead with investigation. In those that have persistent symptoms but are concerned, I think it is appropriate to undergo colonoscopy, one, for reassurance for the patient. If it is IBS, that sort of worry about having a more sinister diagnosis sometimes can impact the IBS. So if there is that constant worry from the patient's point of view, then you would consider colonoscopy as well. Yeah. But it's sort of a balancing act. What's the risk versus the risk of the cancer? Any other question? Yes?
Is there a Bristol description of IBS type stools?
So the question was, is there a Bristol description of IBS type 2? So yeah, it's the same scale, but 1 or 2. So Bristol type 1 or 2 is considered hard. Bristol type 6 or 7 is considered loose. And 3, 4, and 5 are normal. So that's what we use for the diagnostic criteria.
Good, I think we'll end that presentation and move on to the hepatitis level. Thank you.